Absolutely. No question about it. I mean, the irony is that these tools were in place. We had them,
Yeah.
when COVID hit. We just had a really good reason to roll them out, and we did. So I would just say that at our zenith, we had about 22% of our patients were being seen telehealth or video visits during the pandemic. In our behavioral health space, it's maintained a high percentage. There's a lot of reasons for that. I think that the nature of the visit bodes well for a video visit. As long as you can see the patient, you can read their body language and nonverbal cueing and those types of things. So it does lend itself well to that model. On the primary side and specialty care side, to a lesser extent, but remember, concurrently, we've seen record messages through our portal as we're a year into a new platform, and every month we have there's more forms being filled out, more messages being sent and answered. And the other ingredient there, frankly, is the staffing shortages, right? If we were properly staffed up, we'd be busy answering the phone instead of using the portal, but we aren't. And so we use the tools that we have. And my center managers are starting to figure out that, using portal and having the video visits and things, that they're less resource intensive. The standard of care, it might be an argument that it's a little bit less than gold, but the patients are being seen, they're being taken care of. So that's what matters.
Yeah. I could argue that it's not less than desired. It's just different, right? And I think we have to learn new ways to provide treatment and care across a new format. Yeah, the other thing that's interesting with this, Charles, I was going to follow up with you. I mean, obviously, the last 2 years has been challenging for everyone from, talent being in the office to talent in general. The great resignations going on and people are moving around. People are changing careers, like crazy. Has that been affecting you in your operations in a big way, or is it kind of, you're in the kind of Northern California, a little bit more rural area? Is it impactful there? Because I know in our areas, it's in the metropolitan areas, it's crazy.
Yeah, big time. I used to have a full head of hair, man.
Yeah, that was 2 years ago.
No, I think it's really tough, and it's tough on morale. When you have shortages and stuff, familiarity is, for the acute care visit, familiarity is the straw that stirs the drink. It always has. When you have a provider that's worked with an MA for a period of time, they can read each other's minds. They know the dance, right? We have scribes here. It's another member of the team that does a lot of the documentation. When you're short-staffed, you got to plug holes wherever you can. And so people are getting a different team every day, and that has its own stressors. And in the absence of having everything be standardized, that exacerbates things as well. So, yeah, we're not. I think yesterday I checked, and we still have upwards of 50 vacancies out of a 450 person staff. So significant gaps right now.
Yeah, that's what we're seeing with a lot of practices that we work with, and the hard part is that it's just hard to keep up when you're short one person, no less 10 or 50. Whatever the number happens to be. And it just makes everything go slower than you want it to go at that point in time. So big challenge.
I can tell you one of the main services that we're being requested right now is to come into organizations, try to standardize workflows and build training materials around their technologies, because they're introducing so many new employees, they can't keep up.
Yep. Yeah. Yeah.
All right.
Training methods are going to change. That's for sure.